Hello, and thank you for attending the 501R Q&A Forum. I'm your host, Brian Graves, Vice President of Marketing Communications with Connance. Today you will be joining Connance, PARO Decision Support, and Community Health Advisors in an open forum to review some of the key changes in the recently issued 501R regulations, and then engage in an open dialogue for questions and discussion on these requirements. We hope that you'll get a perspective from the panel about strategies to successfully support the new 501R regulations and understand how your organization can create financial assistance and the billing and support collections policies that support them. Today's presenters are Steve Bernard, Vice President of Professional Services at Connance. Connance's predictive analytic technology solutions help hospitals, physician groups, and agencies improve net income, reduce costs, and improve the patient experience. Steve is joined by Neil Smithson, Managing Member of PARO Decision Support, developer of the PARO Score, which is a leading analytic for identifying missed charity utilized by a growing number of nonprofit hospitals and health systems around the country. And finally, we welcome Mark Rukavina, Principal of Community Health Advisors, which provides customized support to nonprofit hospitals, enabling them to improve community health while complying with the new regulatory requirements. With that, I'll turn it over to Steve and get us started. Steve?
So the origin of this meeting, I have had an opportunity to visit a number of our clients since the beginning of the year or so, and invariably we've moved our conversation over to this topic related to 501R and the recent clarification on regulations that occurred back in December of 2014. So time and time again, when I was meeting with many of you that are on the phone right now, a lot of questions came up, and a lot of questions with the common themes. So I felt that it made sense to get everyone together. We could all learn from each other, find out what is unique about your operations and how 501R may be relevant to your financial assistance policy. So 501R, I think everyone understands what that is, but in case you don't, IRS has placed certain requirements on hospital organizations in order to maintain their tax-exempt status. So to be a tax-exempt organization, IRS is basically saying that you need to follow these guidelines to ensure that your care is being delivered in a manner that is in keeping with the tax-exempt organization. So, within the 501R, there's really kind of three major areas that are a focus. First and foremost is the establishment of a financial assistance and emergency medical care policy. So financial assistance policy, I think what we're going to learn today is financial assistance policy or collections policy, if you have that formalized and you follow it, then that's 9/10 of the battle in a lot of cases. So within the financial assistance policy per 501R, things like eligibility criteria, the basis for calculating the amount that you're charging your patients, method of applying for financial assistance, and giving patients clarity into the actions that may be taken in the event of non-payment. So financial assistance policy is a very key part of 501R. Separate to that is also acknowledging on the amount charged for care, for emergency care and medically necessary care. As we all know, insurance carriers have negotiated very favorable rates with their members, and 501R is very much acknowledging that those that are not able to obtain insurance for financial means shouldn't be charged more than those individuals. And then very important and very relevant to the discussion today is the definition of reasonable effort to determine whether an individual is eligible for financial assistance. And so reasonable effort is very relevant to the topic of presumptive charity, and where myself and the three panelists come into play because of our solutions that we deliver to many of you as it relates to presumptive charity. So with that, I wanted to turn it over to Mark, who provide a quick highlight of some of the changes or clarifications that were made back in December.
Great, thanks, Steve. Thank you, Connance, for the opportunity to speak with participants on this webinar today. Yeah, I think we'll spend most of the time focusing on issues related to reasonable efforts, as Steve just said. In the language of the statute, it said that hospitals were to make reasonable efforts to screen people for financial assistance prior to taking any extraordinary collection actions. So the rule was issued at the end of last year, almost 5 years after the passage of the Affordable Care Act. Right at the end of last year, December 29th, final regulations were issued on the needs assessment provisions, as well as financial assistance and billing and collection and limitations on charges, as was previously described. These regulations go into effect on in the fiscal year following December 29th of this year. So for hospitals on a calendar year, you must be in compliance with these final regulations beginning January 1st in 2016. And if you're on a June calendar year, then you'd need to comply with these regulations by June of 2016. So the fiscal year for the hospital beginning after December 29th of this year. That's when these regulations take effect. They pretty much follow what was proposed in the notice of proposed rulemaking that was issued on financial assistance in June of 2012, and then for the needs assessment issues in April of 2013. So it's a combined set of regulations governing these Section 501R provisions. Some of the most significant changes relate to notifying and informing patients of financial assistance. I think the service attempted to ease the burden of notification for hospitals. Previously, in the notice of proposed rulemaking, hospitals were to send out 3 plain language summaries with statements. That's been reduced to 1. I'm not going to get into too much detail on this. And there were some other changes as well. But what I'd like to focus on really are the changes related to the reasonable efforts. You can go to the next slide. So the regulations describe that hospitals are permitted to determine whether someone is eligible for financial assistance under its policy based on information other than that provided by directly by the individual. And this allows the use of presumptive eligibility categories and models. So hospitals might, for example, describe in their policy that people that meet the conditions or qualify for other means-tested programs, say for example SNAP or food stamps or some other public means-tested program, that if they qualify for that program and their eligibility standards are similar to the hospitals, then they would deem them eligible for presumptively eligible for financial assistance. So that's one way in which the presumptive eligibility could work. And another is through the use of predictive models like PARO, which Neil will be describing in more detail. So there's this option for hospitals to describe. They must, if they're using presumptive eligibility, it needs to be described in the financial assistance policy that the method they're basing this presumptive eligibility on and information that's being used to base this decision on. Previously, in the notice of proposed rulemaking that was issued in June of 2012, presumptive eligibility could only be used for the most generous for hospitals. The final regulations expand on that and allow hospitals to not only use presumptive eligibility to qualify people for that most generous level of care, free care, but also the less than most generous level of care, so a partial discount, for example. And but there are certain conditions that must be met if presumptive eligibility determinations are used to qualify people for partial a discount, for example. And the conditions are that first the hospital must provide notice to the individual regarding the basis of that presumptive eligibility determination, and also inform the individual that he or she may apply for the more generous level of assistance under the financial assistance policy. So that means making sure that in correspondence with the individual, they're informed of financial assistance, and then secondly, given a reasonable period of time for which to apply for that more generous level of assistance before beginning any or initiating any extraordinary collection actions. So this presumptive eligibility option is really a safeguard from taking extraordinary collection actions against people that might qualify for financial assistance under your policy. A very important safeguard for hospitals to have in place.
And Mark, if I could jump in, this is Neil
Sure.
Smithson with PARO. From an operational standpoint, if you're sitting on that side of the table, what Mark's saying here, and a couple really key points to get out of this, is one, that your policy should address presumptive charity, and it should be, if it's not already expanded explaining exactly what conditions under which a patient would qualify for presumptive, whether it's homeless, part of another welfare program, or even use an electronic model, and then stating what constitutes documentation when it's not available from the patient. Although this is allowed in 501R, there's no, I guess, overall nationwide ruling from CMS on what they consider to be documentation. So it's up to auditors for interpretation. And our recommendation, and Mark's been very important in this process in terms of updating financial assistance policies, is saying what constitutes documentation when it's not available from the patient. Also, from an operations standpoint, as Mark mentioned, if you're offering the patient less than your most generous level, you would have to notify the patient that they received a partial discount, how that discount, what basis was that decision made. So you would have to, in essence, describe what model application you used, and then give them a period of time to apply for the most generous level. And so generally, the leading practice across the country for hospitals is to screen right before bad debt. So in that case, it's usually an all or nothing proposition. If you are using the PARO model now for a partial discount, you would want to change your business process before these rules are required to be implemented, stating the reason or the basis for the partial, and then give the patient an opportunity to apply. That generally could be handled, though, in a statement process. So all is not lost. You could potentially move the scoring process back 30 days, included as part of your final notice, and you would then comply with the rules here. Mark,
Yeah, good points, Neil. Thanks for addressing those.
Mark,
The hospitals also need to make sure that they process applications promptly from individuals that have been granted this partial assistance, and if they apply for the more generous level of assistance. And the individual can submit an application for financial assistance through the end of the application period, which is 240 days from the date of the first post-discharge statement.
And Mark, just one other clarification there. Although we're required to notify patients of a partial discount, and it's not explicitly stated in the rules, it was mentioned in HFMA conference call with Treasury, we are not obligated to notify a patient that receives the most generous level. So you do not have a notification requirement if the patient receives, for example, if your most generous level is 100% charity, you're not required to notify the patient. You might as a practical application, but there is not a requirement to do that.
Yeah, Neil is right. There was a webinar with 2 IRS staff people who were central to developing these regulations, and they said if presumptive eligibility is used to grant free care, everything, it's done. So nothing further needs to happen. For the less than generous level of care, however, these notifications are required. I think that IRS language on presumptive eligibility, and I know the Healthcare Financial Management Association's medical debt resolution also references using presumptive eligibility. Again, it's I think a leading practice out there for hospitals. A couple other things I want to say about presumptive eligibility. Well, the first thing, very important, it cannot be used to deem someone ineligible for financial assistance. So you can use it to grant assistance, full or partial, but you can't use a presumptive eligibility method to say this person doesn't qualify for a financial assistance policy. So that is prohibited, very clearly stated in the rules. The rules also state that hospitals aren't prohibited from using this presumptive screen or third-party information from third-party sources prior to making financial assistance eligibility determinations. If they're trying to predict which patients are likely or unlikely to qualify for financial eligibility. I think there's an attempt there, recognizing that some hospitals use this possibly earlier in the revenue cycle process than Neil just described, possibly earlier than before assigning to bad debt, to try and figure out how to work the account. So the regulations are clear that this is allowed, but again, hospitals cannot use a presumptive screen to say that somebody is ineligible for financial assistance.
And Mark, as a practical point, just here in terms of operations, generally, you should, as a hospital organization, you should not be using outside data to create any adverse action for the consumer. So just kind of keep that in mind when you think about your business processes. It's okay to provide extra benefit to the patient or use it for the patient's benefit, but you wouldn't want to create an adverse action against the patient.
So again, just to reiterate, if you're using presumptive eligibility, whether it's based on the fact that somebody's enrolled in another means-tested program or using a predictive screening method, either or both of those should be clearly described and outlined in your financial assistance policy. Make sure that your policies and practices are aligned. Very important. Yeah, this is just a kind of a quick compliance checklist for you. Written financial, and again, this is all assuming all of these requirements meet the specifications outlined in the final regulations, having written financial assistance policies. Those policies are to be made widely available. Your financial assistance policy, a plain language summary of your financial assistance policy, and a financial assistance application should all be easily accessible on your website and available to people free of charge. A written emergency medical care policy that can be integrated into the financial assistance policy. Maybe, I know some hospitals are combining that with their EMTALA policies. Written billing and collection policies, that can either be a standalone policy or again, integrated as part of the financial assistance policy, but as Steve said, outlining any of the extraordinary collection actions that hospitals are to be taken after reasonable efforts have been made to screen and deem someone eligible for financial assistance. There are limitations on charges, what in the statute is called amounts generally billed. Hospitals are prohibited from charging. Hospitals must choose a method for determining amounts generally billed and limit the charges for people that qualify under the financial assistance policy to amounts generally billed insured patients. And I think what this really is saying is amounts generally that you would generally expect to collect from that uninsured patient, since, as we all know, everybody's billed the same, but with contractual allowances and discounts, they're not expected to pay the same amount. Your board should be voting on any extraordinary collection actions that the hospital is authorized to take. There's a 120-day waiting period from that date of the first post-discharge statement if someone hasn't applied for and been determined eligible or not for financial assistance. 120-day waiting period from the first post-discharge statement before extraordinary collection actions can be initiated. And there also needs to be a written patient or guarantor must be provided with a 30-day written notice in advance of initiating these specific extraordinary collection actions. Again, presumptive eligibility, if you're using it, needs to be described in your policy. I mentioned earlier the widely publicizing of policies, and an authorized body of the hospital board of trustees, a subcommittee of the board, for example, must sign off on the financial assistance and billing and collection policies. The final one on this checklist is making sure that you have procedures in place to inform and monitor any third-party vendors of for the providers, for the hospitals, of your policies, financial assistance and billing and collection policies. I mentioned earlier there's a 240-day application period from the date of that first post-discharge statement. Accounts may end up at third-party vendors prior to that 240 days, but hospitals are obligated to accept and process applications for financial assistance in that 240-day window. So that's a pretty broad, but I think important compliance checklist for hospitals, and important for both hospitals and any third-party agencies to understand all of these requirements.
And Mark, if I could just make some operational points in what Mark just said. Mark does spend a lot of time looking at hospitals' financial assistance policies and reviewing those, and some of those have been what we call a blind review. And Mark, you might want to speak to that in just a second. How many hospital systems you looked at in which they failed this checklist? Generally speaking, in terms of when we talk about widely publicized, we see patient or web portals that'll have a button that you can pay your bill now, and the financial assistance button will be buried 3 or 4 pages within the website. So that needs to be just as apparent as your payment process. You might not like that, but that's the reality today. And I don't think we can stress enough how important it is to involve third-party vendors today. As Mark just said, the risk is if we're placing the bad debt at 150 and somebody calls and asks for financial assistance in the bad debt cycle, say at day 180, that vendor is obligated to understand and be able to comply with your financial assistance processes and monitor those days in application. So those notification rules, decision rules all still apply, even though it still might be in bad debt. Again, it's just, I think, something hospitals aren't necessarily used to today and is a big change in terms of operation. So where you've had your financial assistance policies maybe in a notebook on a shelf, no offense, it's now important that the vendors also understand and comply with these processes.
Yeah, really good point, Neil. And though the final regulations don't go into effect until sometime in 2016 for hospitals, the final regs also state that for earlier years, hospitals may rely on a reasonable good faith interpretation of the statute. And the statute is pretty clear on widely publicizing policies, saying that they should be widely publicized, and there's other language in the policy. But I would argue that any hospital that doesn't have information easily accessible on their website right now should really move quickly to do that. I mean, my recommendation would be that you try to come into compliance as soon as possible around the posting requirements at a minimum. And if changes need to be made to your financial assistance policies, you've got some time to do that over the next 9 or more months. But as Neil said, I've done some just a random sample of looking at websites out there, and it's kind of surprising that a number of nonprofit hospital websites, there's little, or in some instances, no information on financial assistance. I think that's a pretty perilous path for a nonprofit hospital to be on at this point in time. And then the other thing, just in terms of Neil's and both of us raising the issue of third-party vendors, there are some requirements that patients must be notified of financial assistance. One of the requirements is that a conspicuous notice appear on billing statements that provide patients with information on financial assistance. So I know I've talked with agencies and with hospitals that are working with agencies to try to make sure that the information that the agencies are providing to individuals associated with accounts from nonprofit hospitals, that their correspondence, again, is in compliance with these new requirements.
Mark, we're fortunate to have a number of questions in the queue, and so maybe I can throw a couple of those out to the panel and see where we go from there.
Great.
The first question is from Susan, and she would simply like to know, what are the risks for using scoring?
So,
Mark,
well,
do you want me
I
to
think
take
one
a
of the...
crack at that first, or?
Sure, go ahead,
Go
Neil.
ahead. I guess from a standpoint of risk, probably the biggest risk you have today is that your process is not adequately described in your financial assistance policy about what constitutes documentation. So there is potentially some risk with your auditors, particularly your MAC auditors, but again, it goes back to policy. So, you know, it's just a matter of making sure that you're covered in your policy and it's adequately described. I think that it's very important in today's day and age, particularly with these new rules, that hospitals do seek some assistance and try to get some outside opinion on your financial assistance policy and not to approach it as a cut and paste. I think on the positive side of the risk is that a scoring process ensures that you're screening all patients in a very consistent process, and we're able to assess all patients to our financial assistance needs. I think from a positive standpoint, it helps hospitals improve community benefit. It really helps hospitals correctly categorize bad debt as charity care and really get the recognition for those dollars that are going to languish in bad debt anyway and use those in a productive manner. So, Mark, you might want to add to that.
Yeah, I know. I just want to reiterate what you said, Neil. I think one of the risks is you know, using it in a way that's not in conformance with your own policy. So making sure that your financial assistance or billing and collection policy clearly outlines that your use of presumptive eligibility screen and describes you know, how when you're using it. And I think that making sure that it's uniformly applied according to your policy is really important. And like Neil, I think that there are many positive attributes. One, you don't want to be sending accounts to collection for people who have little or no financial resources to pay. So that's a precautionary measure, a reasonable effort to screen out those accounts prior to going to bad debt. The other thing is related to bad debt is you're reporting on Schedule H. There is reporting on Schedule H of bad debt, and then there's a question of that of the bad debt reported on Schedule H. What portion of it, how much of it is attributable to patients that would have qualified for your financial assistance policy. I think having a protection in place like a presumptive eligibility screen will result in that percentage or portion of bad debt attributed to patients that would have qualified for assistance should be very small. But if you don't have kind of that type of measure in place, I think it's pretty tough to say that your bad debt figures are small unless you've done some pretty extensive auditing of accounts in your system. And then, as Neil said, you can move that not from, you know, it won't end up in bad debt, but you'll be qualifying people as presumptively eligible for financial assistance. You can claim credit for that when reporting on financial assistance or charity care on Schedule H.
Excellent. Thank you, Mark. We have our next question from Michelle. This will take me a minute to get it all out, but she writes that you mentioned that you had participated on a webinar with representatives from the IRS and that they indicated that you don't have to notify individuals that they were approved for financial assistance, specifically through presumptive charity. However, her organization interpreted a piece of the regulations to mean that you would have to provide written communication. She goes on to say the regulations don't differentiate between a full review for financial assistance policies and presumptive, but they assumed it meant any financial assistance determination. What are your thoughts on that?
I'll jump in on that first, Neil. I think I would recommend you go to the HFMA website, and they have the tape of the webinar with the IRS staff posted on their website, so you can listen and hear. They responded a couple of different times to issues related to presumptive eligibility. And I think that certainly that's a good practice if you want to inform people that they qualified for financial assistance, whether it's through the typical application process or through your presumptive eligibility method, whatever it might be, this using a predictive model or qualifying for other programs. And I think it's probably an emerging leading practice for hospitals to do that. But it doesn't appear to be required. And again, you know, some of the language in the final regulations is quite clear. Other language is open to interpretation. Neil, I don't know if you want to add to that.
Yeah, I would. I don't want anybody to misunderstand my statement earlier. If a patient applies for financial assistance, there are notification requirements, and you do have to adhere to those. Specifically, though, when it comes to presumptive charity, this is probably where Mark and I differ a little bit, but it was clear in that webinar that you are not required to notify a patient that receives the most generous level of that presumptive charity decision. My experience of the last 12 years in working with this segment of the patient population, generally feel that notification of free care to that patient base is really a waste of expense. Now, do we want the patient to know they got free care? Do we want to create a revolving door in which the patient isn't required to do anything for assistance? Those are really operational questions you should ask yourself. So some hospitals do notify patients of the PARO presumptive charity decision. Most do not today.
And just to point out in terms of the regulations, the presumptive eligibility determination category falls under the billing and collection and is linked to the extraordinary collection action. So it's really seen as a reasonable effort made by the hospital to make a determination on whether somebody's eligible for financial assistance or not.
Excellent. Thank you both. Just so you know, and just so I recognize Michelle actually sent some follow-up, more specific questions, including a note pulled from the specific regulations, I guess just after publication, that Michelle, I'm going to sort of take that offline with Mark, Neil, and the group so that we can answer your question. But I'm going to move on to the next general question, which is asked by Scott. And Scott asks, can you send the 30-day written notice during the actual 120-day waiting period, or do you have to wait until the end of day 30 of the waiting period?
Scott, thanks for asking that question, really important question. You don't need to wait until after the 120-day period. So that notice could be sent on day 90, that in 30 days you will initiate an action, so that on day 121 you would then be able to initiate an extraordinary collection action. Really good question. And if the person, but let me just add one thing to that, if I could. If a person, but the person does have up to 240 days to apply, and if an application for financial assistance is received after you've initiated an extraordinary collection action, the extraordinary collection actions are to be suspended while a decision is made. And if the person is found eligible for financial assistance, then those extraordinary collection actions, reasonable efforts should be made to reverse those collection actions.
And Mark, along those same lines, Scott then asked, can an account be sent to a collection agency after the 120-day waiting period, even though the patient has up to 240 days of applying for charity or financial assistance?
Yeah, so as I think I just said, extraordinary collection actions could be initiated on day 121, but the patient, but you may want to consider whether you want to do that, since the patient could apply for financial assistance, and the application hospitals are required to process those applications up to 240 days from that first post-discharge statement. So you may have to reverse those extraordinary collection actions. And if a person does apply for financial assistance and is found eligible within that 240-day period, hospitals are required to refund any amount, $5 or more, that a patient has paid over and above what they're financially obligated to pay.
Excellent. So I'm going to move, Mark.
Just real quick, Mark, in relation to refunding of payments, we are not required to refund payments from a presumptive charity determination. Is that correct?
You know, I think it's probably going to be another one of these areas, Neil, that's maybe a little less clear in the regulations, but the regs do, when speaking to the issue of refunds, the regulations in the preamble reference submitted applications. So I believe that's correct. The other thing with the presumptive screening, again, from my experience working with hospitals and working with you, Neil, on these issues, is these screens are typically run on patients that haven't been responsive to attempts to resolve bills or apply for financial assistance. So it's probably far less likely that you're going to have patients that have already made a payment on a particular bill that you're going to be screening. And I don't know, you may want to respond to that, Neil.
Yeah, I think generally that the understanding is that patient payments on the presumptive basis, typically you wouldn't select those patients to be scored anyway because they wouldn't be unresponsive. So, normally if somebody's making your payments, you wouldn't screen them for presumptive charity unless you send that payment plan patient to bad debt. So I don't know how much of an issue it really is in the long run, but again, the general consensus there is you would not refund patients on a presumptive basis.
All right, gentlemen. The next question I have is there on the screen, which is, if we utilize predictive eligibility screening for our uninsured today, are we required to screen our balance after insurance for insured patients as well?
I'll jump in on that one. As Neil said, it's really important to have your written policies in place, and I think the answer to this question it will depend on your financial assistance policy. If you grant financial assistance to both uninsured and underinsured patients, then yes, you should be screening uniformly for the uninsured as well as balance after insurance. If your financial assistance policy is strictly limited to people with no third-party payment, with no insurance, then no, you wouldn't need to be screening for balance after insurance accounts. Neil, I don't know if you want to add to that.
No, I think that's a good answer. That sums it up.
All right, and so the next question we have is, are we required to screen all patients at the same point within the collection process, or can we choose the point in time which is most appropriate for the balance type?
Mark, I'll take this one first if you don't mind.
Yeah. Sure.
You would want to create, part of your financial assistance policy, and this is really important, and I got to keep going back to audit, but it's consistency of process. So you would not, wouldn't think you'd want to create exclusion or exception processes that might be based on balance type. So again, if it's described in your financial assistance policy of what you do with certain balance ranges, then you could deploy scoring at different points in your revenue cycle. The leading practice, again, nationwide, is that patients are screened at a consistent point in the revenue cycle, and most likely that's pre-bad debt. Mark, you might want to add to that. I don't know.
Well, the only thing I wanted to add to that, Neil, was what I had said earlier, and that the regulations do speak to the fact that some hospitals use screening or at different points in the revenue cycle, and possibly earlier in the revenue cycle, to try and determine how to work with the account. So it's really probably a way to using that information as a way to segment accounts rather than simply qualifying them for financial assistance.
Yeah, and Mark, that's a good point. When we talk about somebody ultimately is going to be presumptive charity, and particularly with the uninsured, if we know that early in the revenue cycle, would we launch them down an eligibility path or some conversion to another payment source? So it's really valuable from that context. Again, though, I think you ought to think about when you actually claim the account as charity and make that write-off should be consistent.
Yes.
So you could identify a patient early as a potential charity write-off, but put them through a minimum collection effort of some sort.
All righty. We have our next question from the group, and this is from Noreen. Noreen asked for a clarification. If a patient is found to have charity but has previously made a payment, hospitals are required to go back 240 days to determine any refund that's due.
If a patient applies for financial assistance during that 240-day window, 240 days from that first post-discharge statement, and they've already made payments that exceed what your financial assistance policy describes as their financial obligation. So say, for example, under your financial assistance policy, they would be obligated to pay $50, and you've received a payment from them of $100, then yes, you would need to go back and refund the $50 that is in excess of what they would have been obligated to pay.
Excellent. Thank you, Mark.
And the refunds, there's a threshold on that. The refunds, if it's less than $5, it's not necessary to refund it. And they also state in the regulations that they will be looking at this threshold in the future to see if it should be raised or changed.
Excellent.
Can I just add one other thing to that refund issue, because I think it's important as it pertains to patients that might be underinsured or have insurance.
Sure.
I mean, I think this came up on a call with the IRS that I was on. And somebody asked the question about whether you need to refund co-payments. And again, having your policy in place, having it written and structured in a way that really understands. I mean, I think it's really important to understand the regulations. If your policy describes providing financial assistance for co-insurance and co-payments and deductibles, then yes, if it was made in excess of the amount they would be obligated to pay under your policy, then you'd have to refund that. But I know that many of the clients I work with have structured their policies to exclude co-payments, for example. Just find it would be too burdensome to try to manage that. The other important thing in terms of insured patients is having some language in there that addresses what you might be contractually obligated to do.
All righty. So the next question is up on the screen. What are some of the important considerations when deciding to employ a pre-service or point-of-service presumptive charity screen?
Neil, I think that's yours.
Okay, good. I think the important consideration here is what can you do in your revenue cycle? So when you talk about a pre-service and point-of-service, the idea in using a presumptive charity screen is to help eliminate some of the barriers for patients. I think from a practical matter, though, it's a great tool to start off improving communications with the patient. For example, if I were to pre-register at a hospital and they were using a screening process and it was determined that I would qualify under a presumptive charity model, the message to me might be, hey, great, Neil, we're looking forward to seeing you on Tuesday. When you come in, I'm going to assign you to a financial counselor. Because ideally what you want to do is keep in mind presumptive charity is really, when you think about it, charity of last resort. And so if I could push the patient through eligibility efforts or try to enroll in other programs, or even get some sort of documentation under my traditional policy. Keep in mind that presumptive does not replace your traditional policy. That if that patient becomes application-driven approved for charity, I can create an ongoing state of charity for the patient. So the message in that pre-screen environment or point of service is hey, we recognize you have a financial assistance need. We want to work with you, get the proper documentation from the patient, if that's some sort of condensed documentation, but put them through the financial counseling path instead of a collection path. It ends up being a real relief for the patient. And there's really been some headway made with hospitals taking that tact or track with the patient through the revenue cycle. So, these patients can convert, particularly when they're uninsured. Ideally, if they're presumptive charity, if we know that from the onset, they're much higher candidates for Medicaid conversion, working with your eligibility firms. Just, a great way to open up that dialogue with the patient. Mark, you might want to add anything to that?
No, I think that you've covered it pretty nicely, Neil.
With that, I'm going to go to our last prepared question, and that is, will providers move away from awarding partial charity award due to the less than most generous financial assistance provision?
Mark, if I could answer this first, and then I'll kick it to you. This does come up. In fact, I was in a meeting with a hospital yesterday. Your partial charity is really an important function of any financial assistance policy in terms of the traditional policy. And it really goes a long way with patients in making bills affordable. And that's really the key here. Now, when it comes to presumptive screening, you've got to ask yourself, do we want the extra burden and operational complication from offering less than the most generous level? A pretty strong argument could be made if we make that partial discount and we comply with that notification rule, will the bill become more affordable upstream in the revenue cycle for the patient? That's really a question you should ask yourself, and what sort of benefit. But keep in mind, charity care is claimed at the cost of service, and so if your partial discount does not reach that cost of service, you're really making a discount adjustment. So, again, it's a really important part of it, I think, of any financial assistance policy in terms of the traditional application-driven process. In terms of presumptive, how you deploy it really becomes an operational question, and can we comply with the intent of the rules in terms of that notification? So, Mark, I know you probably want to add to that.
Yeah, I think it really depends on the particulars of a hospital, and whether you're, where most of your charity falls. Is it in free care or partial care? The performance of accounts that are granted partial assistance, and again, especially given those additional notification requirements for patients that qualify for less than the most generous level of care through a presumptive method, there are going to be added costs with that. So it's really something that hospitals should carefully consider based on their the structure of their charity care and their accounts and the performance of those accounts.
All right, thank you both. We do have one final question from the group, and it is from Noreen. And the question is, clarify the requirement for listing the providers other than the hospital itself. For example, emergency physicians, outsourced physician groups. Can physician groups be listed? And are individual physicians required to be listed, or just those who participate?
So the answer to that question is no. And the AHA just recently sent a letter to the IRS asking them to strike that provision. I know in talking with different associations, there are concerns around that. I think it's evolving, and hopefully there will be clearer guidance issued on that. I know that others like you, Noreen, are asking the question, do we need to list this at the individual provider level? Is it sufficient to list certain physician groups or practice groups? I think what would be important, however, is you might know from your own experience that certain services create problems for patients that qualify for your financial assistance. So I've heard from various clients, radiology, anesthesiology, for example, are areas of confusion for patients. They get a letter from the hospital saying you qualify for financial assistance, and then a few weeks later they get a bill from the radiologist or the anesthesiologist that's not employed by the hospital, that's not covered by their financial assistance policy, and people are confused and upset by that. So if you know a certain service line isn't going to be covered, I would recommend stating that clearly in your policy and even in some of the information that you're providing to patients to help eliminate any confusion around that. But I suspect we're going to be seeing more on or hearing more on this issue in the future.
And Mark, I think that this question, that we kind of giggled about it, but it does come up an awful lot. And, you know, I think maybe this is a good part in closing, too, is that generally the IRS will look at this if your intent is to comply. So in a case like this, I mean, we could get very technical about who's listed and who isn't, as Mark describes. You know, think about it from a practical matter. What mostly comes up in complaints in the billing, like, for example, do ER physicians participate? You know, as Mark said, those other services associated with the hospital bill. And I think generally if your intent is to comply with these rules and you've made a good effort to do that, they'll look favorably on that.
Good point, Neil.
Excellent. Well, gentlemen, with that, that is our last question for the day, and I think with that we'll close out our 501R Q&A forum. I want to thank our presenters, our panelists, Mark Rukavina, Neil Smithson, and Stephen Bernard, for all of their insights and great information. I also want to thank all of you, the participants, for your great questions and your time in listening to the Q&A. We are going to make this information available on Connance.com. It'll probably take a week or two for it to get up there, but just come back and visit us, and it will be up there soon. For those of you who may have any follow-up questions, I will leave up here on the screen all three of the panelists' information, so you can go to their websites and reach out to them individually as well. And if you need further information about any of this information, you can certainly get in touch with me directly. Again, my name is Brian Graves, and my email is bgraves@connance.com. Again, thank you all so much for participating, and we look forward to talking to you all soon. Have a great day.